Hi, and welcome to another episode of the Cancer Now What vodcast, sponsored by Arizona Center for Cancer Care. My name is Jenny Martin, and I'm very pleased to be joined in studio today by three community physicians who are going to share their insights on lung cancer. We have Dr. Rishi Agarwal, who is a medical oncologist with Arizona Center for Cancer Care. We have Dr. Alok Surana, pulmonologist with Arizona Pulmonary Specialists. And we have Dr. Chirag Patel, cardiothoracic surgeon with Honor Health. Thank you all so much for being here today. Really appreciate it.
Thank you for having us.
Thank you for having it.
So I'm going to start with something just really basic that we talk a lot about when we're talking about a new cancer that we haven't discussed on the show in a while, and that's really the screenings, right? So I'm going to start over here with you, Dr. Surana. So being the pulmonologist, you are the front line after the primary care physician when it comes to these lung cancer or any kind of pulmonary patients. So how do you recommend screening for lung cancer? What do you tell people when they come into your office to do?
Right. So we look at the risk factors, of course, to begin with, and we follow the United States Preventive Task Force guidelines, which were updated in 2021. So basically, the biggest risk factor is smoking, of course. So anybody who has a 20-pack year smoking history and either are current active smoker or have stopped within 15 years, the data shows that they have a significantly higher risk of lung cancer. So that's where the role of lung cancer screening comes in. So what we recommend is for those patients to have annual low-dose CT scan. This is the screening tool that we use. And that way we can identify potentially problematic growths early enough that something can be done about them before it becomes late.
Okay, so 20-year smoker.
That's correct.
Is that what you said? Okay.
20 pack year smoking history. So yeah,
Okay,
if they have been a pack a day
okay.
smoker for give or take a total of 20 years, and that smoking history is either active or they stopped within the last 15 years. And the age group that we take for that is from 50 years to 80 years of age. So those are the patients who will qualify for this screening.
Gotcha. And then if they're in that category, does insurance usually cover it, or is it a cash pay thing?
No, so insurance actually does cover it because these are, like I said, national guidelines by USPTF. So insurance 100% covers it. We hardly ever have any issues getting this done and approved by insurance. So that's one more good thing about it.
Oh, that's really good. Because I know that a lot of times when people are in our oncology clinics, they want to know how they can get these low-dose CTs, but their insurance will pay for it because they don't meet certain guidelines. And if there's a family history, they still want to be able to get a screening. So it's good to know that insurance will cover it for
100%.
Patients in this particular situation. That's great. Thanks. So let me just take a step back really quickly. I thought it would be good to just, before we go forward, just introduce ourselves a little bit, right? And understand a little bit more about what our roles are. So since I already started here, why don't you tell me a little bit about your background and why you got into pulmonology and all the awesome things that you do as a pulmonologist here in our community.
So I trained in my internal medicine residency on the East Coast with Temple, and I was in Philadelphia for my residency. Post-residency, I trained in my fellowship in Little Rock in Arkansas. And I was there for another couple of years post-fellowship, and then I moved to Phoenix, Arizona last year. And I'm a part of Arizona Pulmonary Specialist. We are a pretty large group. We provide our services to Scottsdale and Phoenix site. Pulmonary was of interest to me because smoking, as you know, is a huge problem, a major risk factor, which is a preventable illness, and you see so much loss of life and debility and morbidity in society because of this. And I feel like this is something, where I could contribute to the society in, helping people with not just lung cancer, but emphysema, COPD, and all the bunch of other medical illnesses that accompany smoking.
Yeah, well, that's great. Thank you for doing that. We appreciate you. Dr. Patel, would you like to tell us a little bit about yourself? Welcome. Thanks for being here.
No, thanks for having me. So I'm a general thoracic surgeon, specifically trained in surgical oncology, dealing with malignancies of the lung, the esophagus, and the stomach. My training was at a Barnes Jewish Hospital in St. Louis, and I've been in Phoenix ever since, practicing in the Valley. So
good. Yeah. Well, we're so glad to have you. Thank
you
you so much. May I ask why you got into this field in the first place? Why thoracic oncology specifically?
So I've always wanted to do surgery. It's one of those fields in medicine that it's kind of an instant gratification where there's You have a patient that's diagnosed with an early stage lung cancer, for example. You go in there and you take that out, and you've dramatically improved their overall survival just overnight. So it's something that's it's self gratification, and I think the rewards are high.
Amazing. Thank you.
Thanks.
And Dr. Agarwal, medical oncology. So happy to have you here. Thank you so much for joining our discussion today.
Sure.
So tell us a little bit about yourself and your field of medical oncology. And you're seeing obviously more than just lung cancer patients in your practice, but why did you get into oncology in the first place?
So, well, just about myself, I did my residency and training in Michigan and Cincinnati, Houston. I did, when I got into medical oncology, the main reason that I wanted to do medical oncology was because of all the morbidity and, myths that cancer brings to patient. And I saw that there was a lot of scope to grow in oncology. When I started my training, oncology was still a field which needed a lot of work, a lot of research. So the aspect of medical oncology which really pushed me towards medical oncology was that it was a rapidly growing field, a lot of new research, a history in making. So I wanted to be a part of that, and that's how I got interested in medical oncology.
Excellent. Well, we're so glad you did. Thank you so much. So back to the screening, okay? So we've got our people that should be screened, right? Is the primary care physician sending them to you if they fall into this category? Is that how they're making it to you?
So it's kind of both ways. Many a times it will be primary care physicians who are on top of everything, and they are having these patients do annual screening. They find something over there, and then they send these patients to us to help with the diagnosis part. And then, as a pulmonologist, obviously I see a lot of patients who are either active smoker or previously smoked, and now they are seeing me for COPD, emphysema, other smoking-related lung illnesses. And so we make it a point that they get the screening that they need. And so we see patients who we are diagnosing with something on the CT scan that needs further evaluation. And many a times we get patients from PCP as well being sent to us for the procedures and try to help them with the diagnosis.
Okay, that's helpful. So if I'm a patient who is with my doctor, my primary care doctor, and if I'm in that right age category, do I have to ask my primary care physician about this to get screened?
Ideally, your primary care physician will bring it up if it's in your history that you have smoked in the past or are currently smoking. So your primary care physician should bring it up to you. But that is the whole point of an educational series like this, because we want to increase the awareness where the patient can take ownership for their own health as well and be the advocate for their health, and they can bring it up as well with their PCP or even a pulmonologist. So that's essentially. But yeah, ideally your PCP will provide this option to you, and most people will take it, and then we'll proceed with the CT scanning.
That's great, though. I always want to make sure that our audience hears be an advocate for your own health care, because while we have so many amazing physicians in our community, there are things that sometimes you just don't remember to tell your patients when they're sitting in front of you, right? So if you are a smoker, if you are over 50, a pack a day for 20 years, you are eligible to have this screening is the message, and you need
100%.
to ask for it.
Yeah, all of this data came back from a multi-center national trial that was published several years ago. And what it showed is that patients who underwent low-dose CT scan screening had a 20% reduction in lung cancer deaths than the patients who did not undergo low-dose CT scan screening, right?
Wow.
So when your question about PCPs knowing this, it's as routine as a mammogram, right? When you turn a certain age, your PCP refers you to a mammogram. When you turn a certain age, you get a colonoscopy. So the trial also showed that you need about 320 CT scans performed to prevent one lung cancer death. Now that may seem like a lot, but when you look at mammograms and you compare that to mammograms, you need anywhere from 370 to 1,900 mammograms to prevent one breast cancer death. So the low-dose CT scan screening, I think, is something that's not very utilized out in the community, and a lot of PCPs don't know about it, and I think this is a good way to educate them.
That's so important. Thank you for bringing that up. I'm very glad that you brought that up. I definitely think about colonoscopies and mammograms, right, and those kinds of screenings, but I wouldn't think about this one, and I guarantee a lot of our audience wouldn't either. So thank
Right.
you guys for reminding them to be their own advocates in that way. So let's say that somebody has this scan, right? And there is a suspicion or a diagnosis of
Correct.
lung cancer.
Correct.
Then it's time for us to talk to the oncologist and the surgeon. So what is the next step after that?
Right. So let's say the CT scan does find something that is concerning. In that case, we can take one of several routes, but most often, the biopsy in the high-risk patient is the way to move forward. So the biopsy can be done sometimes with just bronchoscopy and endobronchial ultrasound. So that is something that we do. Sometimes the growth is more amenable to a biopsy from outside, or sometimes we'll need CT surgery's help where let's say the growth is more on the inner side of chest in the area we call mediastinum. And in that case, we'll send the patient to Dr. Patel for diagnosis. But between us and Dr. Patel, we'll be able to get a diagnosis, and then that's where we will refer the patient to oncologist, and they will be the one who will be evaluating them for further treatment plans. and
Gotcha.
options. Yeah.
Okay, good. And what happens when they make it to you?
Well, so once we, most often we get the patients after the diagnosis is made. I do encourage my pulmonologist in primary cares to send patients even before the diagnosis is made. Sometimes it's helpful, whenever you see something as a patient, you are already, there's so much stress involved with the cancer ward. If a patient is being sent for a biopsy, they're already thinking, what's next, and what's the next step. So I prefer to get involved as early as possible, as soon as, if there is an abnormal imaging finding, so I can sit and talk to the patient that, hey, these are the next steps that you'll be going through, and this is most likely the outcomes, and what are some possible future scenarios. So, but once we get a biopsy results back, that's when we start the treatment planning, and the first step is staging. At that point, depending on what previous scans we had, or we get new scans to appropriately stage the patient. And lung cancer, we could stage between stage 1, 2, 3, and 4. And based on the staging, then we decide the next treatment, which in early stage patients could be surgical resection or radiation, or a combination of surgical resection with radiation, depending on if patient has high-risk features. And more recently, we have also started, even in early stage patients, decide if they need some sort of systemic therapy before and after surgery. So once we get the biopsy, that's the next step, is to decide, what the stage is and what are the treatment options.
So, Dr. Patel, we were talking about this a little bit before the show. Can you mentioned tumor boards, right? And I don't think that people really understand what tumor board is unless you're in the medical community. So can you just kind of elaborate a little bit on what Dr. Agarwal is saying, and that where you guys are all talking about this and how that happens, where you're making the decision collaboratively?
Yeah, absolutely. So, in anyone's cancer care, it has to be a multidisciplinary approach. You can't have just one physician guide the entire care of that cancer patient, right? So we have something called tumor board. We meet here at Honor Health weekly, every Monday for tumor board. And in attendance is a range of medical oncologists, radiation oncologists, surgeons, pulmonologists. We have pathologists and radiologists. So multiple disciplines are coming together. And what happens, there's a nurse navigator for each tumor board. That nurse navigator then collects all the data, collects all of the pulmonary function testing, collects the PET scan images, pathology results, and we present each patient individually. So if it's Dr. Agarwal's patient, he'll present that patient, and we'll review the images from the radiology, we'll review the pathology report, and then we'll review whether or not the patient is a surgical candidate, whether or not they should get induction chemotherapy first, or if they should go for just chemotherapy and radiation therapy alone. So it's a tailored approach, individualized to that patient and their cancer.
And so then you mentioned if it's one of Dr. Agarwal's patients and he's presenting at the tumor board, but but there are obviously, it's a room full of physicians, right? Do you all just kind of like, well, what about this? Could we
Yep.
try that? Like, is it a kind of a collaborative? It's not just the three of you talking about the patient.
Right.
It's the community at large in oncology in this space
Correct,
talking about the
100%.
patient.
You have an attendance of anywhere from 15 to 20 different physicians from different specialties that will all chime in and talk about this patient and give their opinion. Sometimes you have a very complicated case and it's not black and white, and we rely on experiences from the other physicians to help guide treatment, as well as obviously guidelines.
No, I love that because I think that people really think a lot of times, am I with the best physician? Is this the guy that knows or the gal that knows lung, right?
Right.
And to know that you are all bouncing ideas off of other people in your specialty in our community is very reassuring. So I'm really glad you shared that. Thank you.
Right. And, you know, not all hospital systems, not all places where they do deal with cancer have multidisciplinary tumor boards. And we're fortunate that Honor Health has tumor boards for pretty much every malignancy.
That's really good to know. That's really good to know. I thought that was kind of standard practice. No?
No.
That's unfortunate, but I know where it's happening now, so that's good.
Right.
Good. All right. So let's say that you have your tumor board, you're all in agreement that the next thing is surgery. Okay. They're going over to you.
Yep.
Okay. And what's happening? What do you do? All the things. Like I
Right,
know there's a
so-
lung involved and a knife. I don't know
Yeah,
much
exactly.
more than that.
So, you know, lung cancer surgery and lung resections have come a long way. About 10 years ago, most of these patients would have a large incision, 15 to 20 centimeters size on their back. You have to break a rib, get inside to remove this stage 1 early stage lung cancer. Nowadays, most of thoracic surgery is done robotically with little tiny incisions that are no more than 8 millimeters in size. And we go in through the side with the robot and remove the cancer that the lobe is in. So if it's a right upper lobe, take out the right upper lobe. At the same time, we're sampling all the lymph nodes and all the lymph node tissue around that lobe and also in that chest. And all that gets sent off to the pathologist. Surgery takes about 2 hours or so to do, and most of the patients, believe it or not, stay in the hospital just one night. Our average length of stay is 1.13 days right now after a lung cancer resection. Once the patient goes home, we see them in our office in 2 weeks for a postoperative follow-up to see how they're doing, how their breathing is. And then we review the pathology report. And the importance of robotic surgery is that we're able to now biopsy a lot more lymph nodes than we were before when we were doing open surgery, believe it or not. We average about 16 lymph node resections per lobe lung cancer resection. And we've now found that there's about a 13% chance of increasing someone's stage after a lung cancer surgery. So what that means is that if you had a stage 1 lung cancer patient and they didn't have a thorough lymph node dissection and they were stages of stage 1, that would be it. They would just get surveillance imaging. But now 13% of these patients are being found to have what you call occult disease, a disease that's hidden microscopically in the lymph nodes. And so these other 13% of patients are now receiving chemotherapy postoperatively, where before they would not have.
You wouldn't have known until you
Right.
did those biopsies and grabbed the lymph nodes.
Right.
That's interesting.
Yeah.
Can you talk us through? I think that people hear the word robot and they
Yeah.
really don't understand. Like they think. I mean, my mind immediately goes to the Jetsons, right? And there's Rosie going in and doing surgery.
Yes.
I know that that's not it because I've seen the robot in action. But can you explain a little bit and how it's the smaller incision and how you're doing that through the robot?
Absolutely. So it's a machine that has 4 arms, and those 4 arms get placed inside the patient with those 8 millimeter incisions. And then there's a surgical console that I sit at, and I essentially put my fingers in this console. And as I move my fingers, open and close my fingers, that's what the robot does to the patient. So it's not an autonomous machine. It's completely controlled by the surgeon.
Okay, excellent. Thank you for that. That's super helpful. So if the patient comes back and you said the 13% of people are coming back with actually, 13% more people need chemo than what you may have anticipated before the surgery, that's when Dr. Agarwal will get involved, right? So you have the conversation with them. You say, we got the cancer out, but there's, so still some potentially in the lymph nodes. So we want you to have chemotherapy.
That's right.
Okay. And then if you haven't already been with them, they come over to you, right? And so, how do you have that conversation with them? They've got to obviously be in a very confused and frazzled place. They had surgery. They thought it was going to get all the cancer. Now they have to have chemo. So how does that go?
So that's a very important question that a lot of patients when they come in after surgery and the surgeon has told them that, hey, we got everything out. And then when they come to me and then we start talking about, hey, we need to treat more. And that's a moment of confusion because patients are thinking that, hey, I thought the surgery was successful and everything is out. So at that point, we do want to educate the patient why therapy after surgery is still important. Because when you have a locally advanced cancer, and even when the surgeon has taken everything out and the margins are negative, all the lymph nodes were taken out, there is still a benefit of chemotherapy after that because there is still a very high chance of reoccurrence of the cancer. There could be microscopic disease that's left, which are not visible on the scans, and there could be microscopic cells floating around. So at that point, it's very important to educate the patient what's the benefit of doing any more therapy. And most patients are very, once they talk to me, they understand the logic behind more treatment, and they are very open to discussing it further. Because in early stage cancers, the idea is to cure the patient. So what he was talking about, that now with better surgeries, we're able to get more lymph nodes, and a lot of patients are upstaged, which sounds like a bad thing to happen because they thought that they were early stage, but after surgery, their stage went up. But what would be even worse is that we did not stage the patient accurately, and you're treating a stage 3 or a 2 patient as if the patient is stage 1. So if a lot of stage 1 patients, they don't get any treatment afterwards. They don't get any systemic therapy, although there are some newer guidelines where we're doing targeted therapy, pill forms, or sometimes immunotherapy even in stage 1 patients. But broadly speaking, a lot of stage 1 patients don't get any systemic therapy after surgery. And if these stage 1 patients were not really stage 1, because some of the lymph nodes were not taken out, they could be advanced. And so with the newer techniques, we're able to do a more accurate staging. So we know which patient needs post-surgery treatment, so we are able to help them better.
Okay.
Because we don't want to treat a downstage a patient. We want to make sure that we are accurately staging the patient. So a lot of the patients who come with locally advanced tumor, we're doing systemic chemotherapy in some cases. In some cases, if there is high-risk lymph node which comes back, then we also do radiation in some patients. And lately, in patients who are not chemotherapy candidates, we have also started doing next-generation sequencing, where we look for markers in the cancer which will help us treat the patients with targeted therapies, such as pills, which is non-chemo options too. So cancer treatment has come up a long way, where we are accurately staging the patient even better than what we used to do before. And after surgical resection, we are doing better and more effective and more efficient treatment, which has helped cure a lot more lung cancer patients than what we were doing, let's say, 10 years back.
That's amazing. That's really good to hear. And I really appreciate the way you articulate it, and I'm sure that your patients really do too. So thank you for sharing that. Can you tell us what is the difference between, I know it's early in the cancer, stage 1, lower, it's more treatable, right? And then when you get up to 4, that means that there are metastases in other parts of the body. But what are the variants in between?
So broadly speaking, there are many different stages, but broadly speaking, cancer staging is done on three different aspects: the size of the main tumor, the spread to the local lymph nodes, and then the third thing is how far outside the lymph node it has gone, which is metastatic disease. So staging is mostly dependent on the size, lymph node, and whether metastatic. If there is a distant metastatic disease present, for example, if a lung cancer has gone to bones, brains, or liver, or somewhere else outside the lung, that makes it stage 4 in majority cases. in all cases, actually.
Yeah.
Sometimes, even if it's within the lung cavity, if you have pleural fluid, which is positive, or metastatic disease to the pleura, it becomes stage 4. But anything other than that could be stage 1, 2, or 3, depending on the size. So most smaller tumors are stage 1. Once they become big, they become either stage 2, and if they involve the lymph nodes, broadly speaking, most are stage 3. In some cases, it could be stage 2B, but broadly speaking, these are the 3 factors which decide the stage of the patient: size of the tumor, spread to the lymph nodes, and spread outside the primary lung area.
And what's the B in 2B?
So every stage all the stages are further divided into stage A, 1A, 1B, or 1C. So it also depends on, how big, depending on the size and lymph node status.
Okay.
If it's really early, no lymph node could be stage 2A. If there is and one lymph node could be stage 1,
Gotcha.
2B.
So it's just varying degrees of the stages and severity of each case.
Yes.
Thank you so much for explaining that, because it comes up all the time and people don't understand it. And we talk about staging and no one knows really what it means. So thank you for explaining that. So let me ask Dr. Patel, tell me about lung function after surgery. So can you still breathe? Can you, what, I mean, is it hard to walk up a flight of stairs? What do people experience after the resection?
Yeah, so most patients, Dr. Surana, when he sees them in his office, will get pulmonary function testing for them. And that helps us guide as a baseline what their lung function is. So we use the data from that test to see if the patient will qualify for what we call a lobectomy, resection of that whole lung the resection of the whole lobe where the tumor is. If a patient's lung function is adequate and we decide to take them to surgery, within the first 2 weeks, they do have a little bit of difficulty breathing. They have a little bit of discomfort because of the pain from the operation. But after 2 weeks, if they have good lung function preoperatively, they'll do fine. They don't require oxygen. They won't know that part of their lung is missing. They'll have a full recovery.
That's great. Good. That's good. So if someone is diagnosed with cancer, with a lung cancer, is there a way to prevent a metastases or prevent it from spreading?
So yeah, I mean, that's a great question. I think that's where the role of the screening test comes in play, because the cancerous process is obviously going on in the body. People sometimes are hesitant in trying to get tests like this because it's scary. The diagnosis is, of course, this is probably the scariest, word that you can think of when it comes to medicine. But the key to understanding is that gives you the best chance to catch it early enough that you can actually have a curative treatment and completely be cancer free, as opposed to, when it is metastasized, then the goals are obviously going to change from that standpoint. So I think it is a cliche, but as it goes, prevention is the best cure. I think that holds absolutely true in this case.
So people should still get screened even after they've had their surgery or their chemo or any of the things.
So post-surgery also, depending upon what was the burden of the disease, the guidelines vary as to what sort of CT surveillance needs to be done. It's a very personal, interval, but, it would be 3 months for a certain patient. It could be 6 months for a certain patient, but we do, stay on top of that and make sure that there is no recurrence going on. And Dr. Patel will follow him in the clinic or her in the clinic. Dr. Agarwal will, and so will we. So that's, and if we see something abnormal, then again we go back to the drawing board and figure out, okay, what's the best way to diagnose it, and go from there.
Okay, that makes sense. So you mentioned following the patient. So after the patient is diagnosed, how do you follow them through their whole journey? How are the three of you communicating? How are you following with your patient? And I'm going to ask you both the same questions, how we're following patients and communicating.
Right. So it truly is a multidisciplinary approach because, I have their number on speed dial, and, anytime we have a question regarding a mutual patient, we do not hesitate to reach out. And we talk about, what we are looking at, the perspective from each other, and that way we can, have a shared decision making. And then we will, of course, like I said, we will have the CT following. You will have a detailed history, physical exam, all those things as well in the clinic visits. And that's where, the regular visits in the clinic, the regular scans, they come in the picture. And anytime we see that there is any clinical signs or anything on the scans that needs further attention, then we are able to tackle it right away.
That makes sense. Anything to add, Dr. Agarwal?
So yeah, I mean, cancer surveillance after completing treatment. So going back to your first question, can you prevent metastatic disease once the cancer is diagnosed? So exactly what we are talking about, that accurate staging. So we can devise the best treatment plan. So you get surgery, you get radiation if patient needs radiation, and then either pre-surgery. Now we are also doing pre-operative immunotherapy in patients who are eligible, and post-op treatment. So if we stick to the plan, there is a very good chance of cure, even in stage 2 and 3 patients. So it's very important to accurately stage, accurately do their diagnosis, what's their pathology, newer modalities like next generation sequencing, liquid biopsy. So we use all that information, and then we discuss about patients in tumor board to come up with the plan which will prevent them from becoming stage 4.
Great.
And once the treatment is done, we do have a very close follow-up program. We communicate with each other. We have, Tiger Text, which is a very HIPAA-protected communication that we physicians are using. Besides that, EMR messaging, we do that. And, regular scans, regular clinic visits. We do regular blood work. Sometimes, things can be seen in the blood work which could suggest a new spread. So we are also doing that, because sometimes, let's say, cancer, unfortunately, if it spreads to the liver, you can see some changes in the liver tests that we do on blood work, and then that can tell you that, hey, we need to do a CT scan or something else like that. Lately, we are also using circulating tumor DNA. That's a newer modality that we have been starting to use. That's a blood test which sometimes find cancer DNA in the blood before cancer is even present on the CT scans. So we use everything that we have in our arsenal to identify if there is a cancer reoccurrence, and so that we can act timely. A lot of cancer reoccurrence, if it happens also can happen locally too. And these patients can have a second chance of cure. If it recurs locally, you can treat them with the definitive intent. And sometimes, unfortunately, cancer, when it comes back at stage 4. But the goal is to identify a recurrence as soon as possible, so appropriate actions can be taken.
So you can effectively manage it. If you didn't get it the first time, there's still options the second time if there's a recurrence, if you catch it early enough.
Yeah.
Yeah, that's good. Very good. And Dr. Patel?
I just want to echo what both
Yeah.
of these guys said. We are in constant, maybe sometimes too often, communication about these patients. So from, hey, this person just got their testing done, this is what it looks like, or hey, the MRI got done, and I'm worried about this part of the MRI. There's constant and full communication between the three of us.
That's so important, and I really want to emphasize to the audience that occurs despite the fact that all three of you are with different practices, right? So I think that people don't really understand necessarily, if you're all at one hospital, that's the only way that it happens. But as community physicians, you're talking just as much as if you were all under one roof.
Right.
And I think that's really key for people to understand. So thank you for that. So you mentioned a little bit, Dr. Agarwal, about how treatment has changed over the years for patients. You mentioned immunotherapy. You mentioned this chemo pill instead of, I don't even know if it was chemo, but it was a pill. There's been changes in surgery. Robotics have really brought us a long way. Immunotherapy. So is there anything on the forefront that's exciting in this space? Is there anything you guys want to share with us that you're excited about when it comes to newer treatments?
Yeah, so I think advancement as far as that goes in the diagnostic field, as Dr. Patel, mentioned about the robotics, the role of robotics in the curative part or the surgical part, robotics have actually become a very important modality available even for diagnostics. So let's say we have a patient who, with all the smoking history that they've had, are probably not the best candidate for having biopsies done with a larger needle from outside because of the risk of lung collapse, bleeding, and as such. we have minimally invasive procedures available now, robotic biopsies that we can do with the bronchoscope, and the tools are extremely tiny. The risk of lung collapse and bleeding goes down significantly, and you are able to get diagnosis for those patients as well. So that's definitely a game changer for a lot of patients who would otherwise not be. Who would probably not even get to the point of diagnosis, because you will think that they may not even survive this. So what's the point in going forward and thinking about curative options and treatment options? So I would say, as far as the diagnosis part is concerned, I think that's one of the important advancements.
You can do it in a minimally invasive way
Correct.
that people are going to actually benefit from, rather
Exactly.
than get hurt more.
Exactly. So it's a procedure essentially, which is, so you will be, just to go over that briefly, it will be under anesthesia, and anesthetists will be bedside, and they will be taking care of your breathing and the rest of the parameters. And the procedure would typically takes about 30, 40 minutes, from start to finish. We will watch you after the procedure for up to 2 hours or so for most patients, and if you're doing well, and at that point we will let you go. So it's a day procedure. You come in with somebody who's driving you back, but you resume your normal life the same day pretty much.
Is
So
it in a surgery center, or is it in a hospital, or in your
it is
clinic?
it is done in the hospital.
Okay.
So we do it in
'cause
Honor
of the
Health as well.
anesthesia.
Correct.
Mhm.
Exactly. So we do it at Honor Health as well.
Okay.
And so that will be the place where we'll do it.
Okay, very
I
cool.
think that the one other thing to add, so I think Dr. Surana is talking about the ion robotic bronchoscopy. The other benefit is that, when we send these patients for biopsies to radiology, for example, if it's a small nodule, let's say 4 millimeters, they don't want to biopsy, it's too small. But this technology now lets us biopsy smaller lung nodules so we can get an earlier diagnosis. Additionally, if you have, let's say, a nodule in the upper lobe and another one in the lower lobe, Dr. Surana can go in there and do the biopsy of both of those nodules at the same time.
That's huge.
Yeah.
That's huge. Wow, that's really incredible, and it can really help people catching it early. That's a big
Absolutely.
deal. Very cool. And I bet you appreciate when we catch it early,
Yes.
because then you can treat it more effectively.
Yeah.
Yeah.
Early catching cancer early is, a lot of, throughout our journey in cancer education, you hear this question: can cancer be cured? So the proven effective method to cure cancer is to diagnose early and treat it. So yes, cancer can be cured if you can diagnose it early, and screening is the best way of doing that.
Fair, that makes sense. So I'm just going to ask one more question, and then we'll wrap up. But what I wanted to understand is, what other support services are available to people who are going through this? I know the hospital has got, you mentioned the nurse navigators are following patients through their journey. I know that there are patient navigators in oncology. I'm sure that you have, a team of support services. What does that look like?
Yeah, so you asked me earlier a question about the financial viability of this option, and that's a very important question. All the modalities, the greatest and the best, you can have it, but what point is there if you are not able to afford it? So that's where our team comes in play. Once you step in our clinic, we take the ownership of everything. We have a staff dedicated to prior authorization, contacting your insurance, and trying to make life as easy as possible for you in this tough time. So the patient is scared enough already going through all this. It's only fair that we do not overburden them with this aspect. So that's where our team comes in, and we arrange for the scans, we arrange for the biopsies, we make sure your insurance is going to pay for that, and all that is taken care of. And even post-diagnosis, after they have either had surgery or chemo, we continue to follow them in the clinic. We do lung function tests and things like that. And like we have emphasized over and over here, that this is truly a team approach. All three of us and the tumor board, like we talked about, it's a very multidisciplinary approach. So support is available at every point.
Oh, that's great. That's great. And what about in the oncology clinic? What kind of support services are patients getting when they come see you?
So in oncology service, we have a social worker who helps with financial planning and helping with any financial signs of distress. Whenever we see a patient, all our new patients, they fill up a distress tool, and based on that, we can have that distress, whether it's emotional or financial, and based on what we find on that tool, we act accordingly. So there is a social worker, there is nurse navigator, who play a big role in supporting the patients. A lot of my patients, they will call the nurse navigator first before they have. And majority of time, the nurse navigator or nurse educator is able to answer their questions and find them the resources that they need. We have a very robust pharmacy services. I was telling you about previously about cancer pills, which can be given in selected patients, and those could be quite costly. But we have a very robust pharmacy, and we have a very robust financial support service team. And I can tell you that none of my patients that I have seen in Phoenix so far has to pay anything out of pocket.
That's amazing.
Yeah, so it's there's a lot of planning and a lot of work that goes into making sure that the patients are treated in a manner which is easy for them and their family. So it's not only the patient. We want to make sure that the families also are well taken care of, and if they have any stressors, we talk about that. So I make sure that during my visits with the patient, I make sure to talk to the family members on how they're dealing with this and what can we do to help them in this journey.
That's so important because it definitely affects the whole family and all the people in the patient's life. So that's really important. Thank you. And Dr. Patel, support services?
So from our standpoint, we just have our nurse navigator, right? So that's the person that's going to help the patient get through all of the testing, the cardiac testing, if there's a pulmonary function test or a PET scan or MRI, to kind of get all that stuff arranged, help them be a phone contact person to say, hey, I didn't get this, or I can't get through this imaging place to get my scan. We'll help them facilitate that. But for the most part, I think oncology does a fantastic job about having that social support system of social work, case management, counseling, all that stuff available for them.
Yeah, and there are so many community resources available to people also, and I know that the navigators are really familiar with those organizations and help people connect the dots when they're just too overwhelmed to do it themselves. So, well, Dr. Patel, Dr. Agarwal, Dr. Surana, thank you all so much for being here and having this conversation with me today. I got don't smoke, I got get scanned, and get diagnosed early.
You got it.
Right? All right. Well, thank you so much. And thank you so much for joining us today. If you would like more information about Dr. Agarwal, you can go to arizonaccc.com. If you'd like some more information about Dr. Surana, you can go to azpulm.com. And if you'd like more information about Dr. Patel, you can go to honorhealth.com. Thank you so much, and we'll see you next time.